This is the Convergent Science Network podcast. Leading researchers in the domain of neuroscience, brain theory, and technology are interviewed by Paul Verschure and Tony Prescott.
So it's the Convergent Science Network podcast at our 10th anniversary BCBT Summer School. I'm here with Aurore Thibaut of the University of Liège in Belgium and University Hospital, where she investigates consciousness. And in your talk this morning, you gave us a very extensive overview of the different approaches that people take to assess clinically the level of consciousness of patients. So what are the exact problems there that you face in the clinic in assessing consciousness?
So there are different types of problems that we can face. So we have to understand that those patients, they have really, really severe brain injuries that we can't always objective. And so some patients, they have aphasia, so they can be fully conscious, but they just don't understand when you are talking to them. Or they can have severe motor impairment, or a lot of pain that also reduce the level of consciousness, or like the way they can express consciousness. So we have to understand those patients. We need ourselves to be patients. So this is from the clinical point of view that it doesn't mean that if a patient, when we ask something, if we don't see something, it's not that the patient is not able to do it or doesn't want to do it, but it may be because his state of vigilance is low, or is in pain, or is just paraplegic, such things. So this is from the clinical point of view, like from a clinician. But we also have to face families' expectations, for instance. So we need to, of course, we want to see a sign of consciousness. We saw earlier this morning that it's so important to detect such signs of consciousness because we know that it will affect the prognosis, but also it may affect end-of-life decision and a rehabilitation program, the effort that will be put to bring this patient to a good rehabilitation program, and so on. So it's really important to detect this first sign of consciousness. But on the other hand, we need to be clear and we need to be sure when we see something that it is true and like it's something that is conscious and not just a reflex. So somehow it's really hard that we have this scale. And so, for instance, we have the auditory function and the command following, and the patient needs to do it like at least 3 times out of 4. So I'm going to ask you, try to squeeze my hand really, really strongly. And if the patient does it only twice out of 4, then it doesn't count. And sometimes also it's because that's the rule. We need to have rules and we need to be sure that it's not like a grasping reflex, for instance. So this for us, it's also hard, but for the family, it's really hard to make them understand that all the movements they see, or sometimes they have the impression that their son, they are following them in the room, and to make them understand that this might not be a sign of that it's not a real visual pursuit or such thing. So it's really hard sometimes to disentangle like what is actually conscious and what is not, and us as clinicians trying to find us sign of consciousness, but we need to be 100% sure that it's conscious, and with dealing with the families with all their expectations. So it's sometimes really challenging.
So how many different, let's say, levels or forms of consciousness do you distinguish in the clinic?
So as disorder of consciousness itself, so far we really like to categorize and to subcategorize. So far, consciousness, at least for patients like us, has been seen as dichotomic. So you are conscious or non-conscious. Now we think that it's maybe more like a continuum, but now we have different, states. So we have the patients that are in coma, no eyes opening and no consciousness of their environment. And then you have the vegetative state, we prefer now unresponsive wakefulness syndrome, where the patients recovered eyes opening, but that doesn't mean that they are conscious. It's just eye opening, and it's not even related to sleep-wake cycle. physiological sleep-wake cycle. And then you have this minimally conscious state where the patients are minimally conscious, but are still not able to communicate. So you can interact functionally with them, but they can show some sign of consciousness. And in this state, there are the minimally conscious state minus, a non-reflexive movement. And then when they recover some language abilities, such as command following, intelligible verbalization, or intentional communication, we say that they are in minimally conscious state plus, because they can understand us a bit.
So now, how many patients are we talking about?
How many?
Patients. So in the general population, how many patients do you encounter?
So luckily, it's just a really very small populations. So, for instance, it's a couple of hundreds I know in Belgium, and same in the Netherlands. So it's really, not a lot. That's also something that's why it's so hard to find treatments for them, because it's not as stroke or Alzheimer when, we have like so many pharmaceutical therapy companies that will try to sponsor your study. So it's really hard to get attention for such a small population of patients.
And then what's the accuracy we have today in assessing the state of these patients?
So clinically, we know that if we use the GCS, or the Glasgow Coma Scale, which is the one that is the most used in intensive care, where we really need to assess correctly those patients, in fact, the rate of clinical misdiagnosis is still 30%. So it's really high. Then if we use a more accurate scale, such as a Coma-Berkeley scale revise, so true, maybe we will be able to correctly assess, like we thought before, 102% of the patients, because it is still the best clinical scale, the most accurate. But still, even though those patients are clinically unconscious, when we assess the patient with different types of neuroimaging tools, then we still see that about 30% of them, so 1/3, present brain activity that is closer to either minimally conscious state or even higher state of consciousness.
Okay, but then you also in your talk described a new approach, which was like combining perturbations of the brain using TMS with different complexity measures to look at what the impact is of these perturbations on brain networks. And you show to us that if you then use the appropriate classifiers, like support vector machines, I think is what you used, that you can then rather accurately distinguish these different patient groups. So do you really see that then as a solution to this diagnostic problem you're describing?
I think in the intensive care or like early rehabilitation units, it's still not a solution, because I think it's in too early stage, and it's almost impossible in this stage to implement that in clinics. It's really made for research centers. So in that like practical point of view, we will not be able to do that like today or tomorrow. But I think maybe in the near future we are working on that, on different paradigms, or like using other stimuli rather than this TMS, that transcranial magnetic stimulation, and also simpler or easier to interpret, or direct, like an algorithm that could give a direct feedback of the state of the patients, like this PCI, this perturbational complexity index. If this could be done, like, if we could get a response like 2 minutes after, then that, yes, I think at this point, this could be useful, even though we are still investigating in that technique. And we discussed that earlier today. We said that so far the accuracy is 100%, and that we can detect consciousness at the single patient's level, which is already like a huge step as compared to other techniques such as MRI and PET scan. However, that doesn't mean we still need to understand that if a patient is diagnosed as being in a vegetative state because of the index. That doesn't mean that for sure he will never recover, because we did that with like subacute chronic patients. And then they were like 2 years post-injury, and then they in vegetative state or unresponsive wakefulness syndrome. And then we did this TMS EEG, and we saw that, they were above this threshold and then, okay, and 1 year follow-up, indeed, they recovered. That's great. But we now have to do that, like, at different time points, at 1 week post-injury, at 1 month post-injury, and so on. And just to have like a better understanding if when can it predict the recovery? If it's only for chronic patients, or it can be also for acute or subacute. And this still we don't know. So we still have to investigate in that sense a lot.
Mm-hmm. But now so if you look at this classification, you have also distinct threshold values, right? Where you say, well, below this threshold of complexity in the response, it's a vegetative state. If it's above that threshold, it's minimally conscious. And then there's a next threshold after which you might say, well, this patient is actually normal, possibly asleep or will recover. So, but now if you talk about life and death decisions, right? Do you really see this measure that is there going to be a threshold value where you're going to say, well, below this threshold, we can switch off the machines?
At this point, we can't do that.
Sure.
We can't, because as I said, we don't know when. I mean, we did that again with chronic patients and then they recovered. But like now in the acute stage, we can't use that threshold because we know that the brain, maybe at that time we were sure that the patient were in unresponsive wakefulness syndrome, but that doesn't mean that, this patient that had the injury 3 days before, that maybe 2 days later is going to recover. That we don't know. So today we really can't use that technique.
But do you think it will go in that direction? Would you recommend it?
I think we need to do studies to do like, TMS EEG in the intensive care, like very early as we do the N20, the somatosensory evoked potential and so far this is the only technique and only diagnostic tool that we can use to make and with like a very high, sensitivity rate to make sure the patient the chance of recovery are like minimal. And we know that, this kind of like, treatment withdrawal are done based on this, N20 test, but that's the only one. So if one day TMS EEG is going to be used for that, maybe, but I'm not sure. I think it's going to be a good predictor of recovery, but I'm not sure if we were going to be able to use it as early as the intensive care.
Okay. So then, but how objective is the method really? Because so you depend now on the TMS. That means you have to stimulate at a certain location with a certain intensity and a certain duration. You have to measure at other locations. But now, dependent on the lesions that patients have, you might have to introduce variability because an area where you stimulated one patient, that area isn't there anymore in the other patient.
Right.
So how do you assure that the method stays objective?
So far, I think that there are really a few patients where we couldn't do it. That was impossible to apply the test. So because we have different stimulating areas, and so far we were always able to find one that where we were sure of what we were recording was true. But that's true. We have to adapt to the patients. Also, something that is really important that like now it takes hours to do it. So that means that we can't, if we take the example of the intensive care, we can't apply this TMS for 3 hours. It's impossible. It's like practically impossible. So there are like many, many limitations that that's why it's still in the research process. That it's not going to be tomorrow that we are going to use it in clinic. But there are like a lot of limitations that we need to surpass and to see how accurate it can be, where we have to place the stimulation, depending on the patient's brain lesion, or if we can, a solution, and this is what we are, gonna do soon, is, to test other types of stimulation, like, for instance, maybe we can use like sounds, which is way less invasive than TMS. But as you said, like TMS, the problem is if we are simulating a brain region that is dead. We stun what if the patient is deaf. So we are always gonna face limitations. But yeah, I think the thing is we need to see what is could be used in most of the patients and what can be easily implemented into clinics. Because research is beautiful, it's really exciting, but at the end, the aim is to be able to use that technique to have like a proper diagnostic. So for example, in Liège, we are really lucky. So we can see the patients for a week. And then we can do TMS EEG, we can do fMRI, we can do PET scan, we can do high density EEGs. And then with all those tests and like many clinical assessments, then we can pose a diagnostic. And even though we're not like 100% sure, what if it's only high density EEG showed some sign of consciousness? So it's always a long discussion, but even with all those techniques that are amazing, and I'm not sure how many centers can provide that, we're still not 100% sure sometimes. We are still some dose, and then we follow the patient and we can see, oh yes, this patient recovers something. And so, yeah, it's still a discussion, but we need to make neuroimaging tools available and that can be used in clinics. So that's why I think that EEG is a really good option. We can find like with entropy, like it's like just 3 electrodes, and we can already do good measurements. But we also need to find the algorithm behind just to make them so they can analyze the data like real time. And so can give a feedback, like a real time feedback. So we talked about the communication in the fMRI. And then, it's amazing to know that 30% of the patients are actually conscious, even though they can't show that to us and to the family. But we can't bring the patients to the fMRI every time we want to ask them a question, right?
Right. But then, okay, on the one hand, of course, the clinical objectives of these measures, which are really very important and relevant. But on the other hand, studying these patients must also help us to understand consciousness. Mm-hmm. And this is also one reason why this whole research field is driving itself forward. In your presentation, you made an important distinction there between what you called an internal consciousness and an external consciousness that you felt, at least in these patient groups you look at, is always popping out as an important distinguishing feature. So what do you mean exactly with internal and external consciousness?
So the internal consciousness is the consciousness of yourself. So what we call also like the little voice. Okay. So when you are for instance, you hurt yourself when you're in pain and then you focus on yourself. So this is like really, or when your internal thoughts, that's the internal consciousness. And then external consciousness gonna be the consciousness of your environment. So if you're listening to someone talking, this is the external consciousness. And they are anti-correlated. That doesn't mean that if one is up, the other one is 0, but that usually if you're like fully concentrated on yourself, you will be less aware of what is happening around you. And this has been shown like many times, and the contrary as well. And so we did a study where we compared those two kinds of consciousness. So more internal related thought, and then more external related thought. And then we compared the network that were activated for one and the other. And so we saw that we had like the external consciousness network, which is the lateral frontoparietal cortices, and then the internal one, which is more like the mesofrontal cortex, anterior cingulate cortex, and then precuneus and posterior cingulate cortex. So one is external for the external consciousness network, and one is more internal for the internal consciousness network. And normally they should be anti-correlated. So when one is activated, the other one is not.
So the internal consciousness system you would then equate with a more metacognitive self-reflective state. It's not necessarily the experience of hunger or of a state of the body. It's really more a metacognitive self-reflective state.
Yeah.
Right? Okay.
This is how we do, but maybe we do it like in a more simplistic way of that's the way we categorize consciousness between two components, awareness, wakefulness. But yes.
But then do you envision that also as, let's say, two subsystems of consciousness that sort of exclusively are active? It's either one or the other?
No, so it's not exclusive.
Okay.
It's not exclusive. I mean, I'm not saying that, again, if you are listening to me right now, you're not conscious of yourself at all. It's like, but one is highly activated, then the other one is less activated.
So they are in a competitive relation. Is that what you would say? Are they competing?
I'm not sure I would say that they are competing, but at least, for instance, with a new study, but there we were focusing on the default mode network. And so we know that within the network, we need to have like the area needs to be highly connected. But then we found out that in patients with disorder of consciousness, we also have, hyperconnectivity, which is pathologic. So, for instance, in LC control, when the default mode network is highly connected, then there is no other connection with other brain regions. While in patients, you have this hyper connectivity. Meaning that concurrently at the same time, the areas that are that should be connected in the default mode network, then there are also other areas are also activated, and this is like the pathological hyperconnectivity only seen in patients with disorder of consciousness.
But in this case, connectivity would mean some correlation structure in the data that you measure from that brain, either EEG or fMRI.
So here's the fMRI, and
fMRI.
yeah. So
it's a rather slow signal, and it's related to, let's say, correlations among the different measurement points.
Right.
But now, would that mean that some correlations go up that connect these subsystems? Or are the intrinsic correlations within the subsystems going down, so you are revealing the inter-subsystem correlation? Can you distinguish these two explanations?
These are really good questions, but you mean like, I would say that depending on the state of your mind, then one system will be first activated, and then the other one will be less.
No, but from a pure, let's say, fMRI perspective, what I'm measuring is correlations among my voxels, right? And you could say for the control condition, I see a certain correlation within these two subsystems, and I don't see it between, right? But now you could argue that underlying that is some causal structure, and that maintains this intra-module correlation, and as a result, you don't see any inter-module correlation. But now, in the coma patient, it's this intra-module correlation that you might lose, and as a result, you are unmasking this relationship between the two modules, right? So is it really indicative of anything that is specific to these states of consciousness, or is it just like an artifact of, let's say, losing internal coupling within systems? So that's a bit the question I'm after. Can we distinguish that? I
think that's in the state that we are now, where we are not able to do that, like as specific. But, I think that it's more like in coma patients, then it's gonna be this more like anarchic, activity. And as like so many brain regions are damaged, then it can be possible that one of them is trying to be activated instead of the other one, and then it just creates some kind of anarchic connectivity that is like, in fact, that creates more damage, or at least functional damage, that so more like an anarchic. Right.
So now then, what you also then discussed in that context was the subjective experience in that sense of these patients, and in particular you talked about locked-in syndrome patients, where you looked at their reported state of, let's say, satisfaction with life or happiness. And you had this surprising result that actually they showed levels of satisfaction or happiness with life that was comparable to healthy controls, which of course to us sounds very counterintuitive, because their bandwidth of communication with the world is severely reduced. So how do you interpret that result? Do you really think it is an accurate reflection of their state of being? Or is there some, let's say, recalibration also for them of what happiness means?
I think I think the two propositions are correct. So first, it needs to be said, and it was acknowledged in the paper, that we send the questionnaires to thousands of patients and only a small proportion replied. So it's possible that we got the reply from people that are actually not that depressed. That's a possibility. So maybe this really interesting result where we see that the patient in Locked-in syndrome on average are not unhappy, but they looked as happy as healthy controls. On average again, not at a single subject level, but so that's a possibility. And then that's true that those patients, they can find their happiness in other things that for us is almost impossible to conceive, because we are not in the way they are. I met a lot of locked-in patients, and they are going on vacations. That for us, like, oh, how can they go on vacation? But they do, and they go like twice, 3 times a year, and they still have like a really good relationship with their family. But one thing that we found out in that study and other follow-up studies is that the more a patient is able to interact with the environment, the happier he is, which makes sense. So that means that's true. Interaction with your environment is an important factor for a subject, someone to be happy. So, I don't know. It would be like so interesting. For instance, we had those patients that are like in complete locked-in syndrome when even they can't move their eyes. So the only way, we had a case of patients like that. So it was impossible to know that the patient was conscious without neuroimaging. It was impossible. And we did this, she was conscious thanks to the PET scan. And we thought, oh my God, but the PET scan looks like you and me. It was impressive. And then we did other tests, and they all say, okay, yes, indeed, it looks like she's conscious. But still, it was she couldn't communicate like how we're used to see in Locked-in syndrome, with the eyes, no movement at all, nothing. And so, yeah, can we say that this patient might be happy in a way? I have no idea, but this is a question that could be asked.
But now with these patients, you also showed us that there are methods that use fMRI recordings with mental imagery to help people to at least give yes and no answers by imagining that they are behaving in some context or they're navigating some environment, right? And do you think this would be a useful interface for all these patients, or you think it's too cumbersome, that's not going to work yet?
I think the EEG one is going to maybe be easier to apply, in clinics again. But also the thing with all those motor imagery is that we have a really high rate of false negative. So many patients in minimally conscious state that are clinically answering to comments, they can't perform the task. And also 75 to 80% of the healthy control, they can't do it. So we also need to find a way to make sure, like an easy way and a way, like a motor task that can be, done by almost everyone.
And how are you going to deal with the variability of the neural response across all these patients?
Repeated assessments, I guess.
Mm-hmm.
Yeah.
Okay.
There is no other solutions. We did a really nice study that was published really recently in Archive of Neurology, and we have to do at least 5 clinical assessments. So if we take these 5 clinical assessments, maybe that we need to do 5 fMRI or 5 EEGs, and it's kind of burdensome, but they're fluctuating, so we have no other options. We have to deal with.
Could you imagine that in those patients we start to implant devices, an ECOG or something, to measure states of the brain to actually help communication? Would you see that as a way forward?
Yeah, I think we not us, but other labs are doing it already with locked-in patients. So yeah, this is something that may be useful, and maybe also to find like the perfect time to say, okay, this is a moment when we have to do something with the subject.
Right. So now in your talk, you also showed us a possible, let's say, mechanical interpretation of states of consciousness that focused very much on the thalamocortical system, going back to Nick Schiff and others, where they looked at it's basically the modulation of the thalamocortical system that will define these states of consciousness. And in that specific model, you also look at additional subcortical loops over the basal ganglia and so on, right? And it's a bit a sort of model you might also apply to Parkinsonism or so on, right? So it's really whether you are switching the thalamus in pathological states of low frequency bursting. Do you feel that model is sufficient to understand these patients you look at, or is it more like really a very first approximation of what we need and what is missing?
So, I think so far it has been a really nice model that can explain why some treatments works and why other don't. The most impressive one is the zolpidem, of course, but so far it fits. And for instance, with TDCS, we have tried TDCS in different cortical areas, and the prefrontal one is the one that works the best. So we were okay, yeah, it makes totally sense. But true, I think it's still like an hypothesis, but it's a nice direction if we need to try new treatments to at least have a rationale behind what we do, and that could be some help if we want to target some specific brain regions.
Right, but the model does not really account or include the role of neuromodulators, for instance, right? It doesn't explicitly take it into account.
Sure, I think it doesn't take into account everything. Mm-hmm. It's really specific to. It was like, I mean, the model existed before, but it was used for disorder of consciousness due to zolpidem because it was really specific to this drug. And I think that this might be really useful to explain again some treatments, but maybe only in anoxic patients because maybe the striatum is not injured at all in some traumatic patient, and then why TDCS is working. So no, of course, I think it doesn't fit everything, but it works well, and maybe it works for very, very specific patients, and then we can fully use it to try to treat them and improve their recovery. But we still need to understand that better.
Mm-hmm. Okay. So look, so you finished your PhD in Liège with Steve Lorais, and now you did your postdoc in Boston, and now you're moving back to Liège to sort of build your career as a young and upcoming scientist. But now in your experience in this field, and also as a clinician, what would be Aurore's law to study consciousness and the mind?
I think I would like to believe that the unresponsive wakefulness syndrome does not exist, and we don't have the tool yet to detect consciousness in every patient. We have seen patients that were in unresponsive wakefulness syndrome for years, and then one day they recovered. Like 3 years later, they were able to talk, even though because of severe spasticity and motor impairment, they will never be able to walk again or be like independent, but still. So I think I would like to believe that this is a possibility and to try to find a way so we will be able to find this consciousness even in patients that are like clinically unresponsive.
So it's keep hope. Always keep hope. Okay, and then, so 5 years from now, I'm going to come visit you in Liège, whether you like it or not. And I'm gonna check then whether a prediction you're going to make today was falsified or verified. So what's the one prediction that you would like to see really tested in this 5-year framework or time frame?
So I'm gonna be really clinical again, but I think that a lot of treatment options are available, but we can't use them. And I would like to stimulate the translation of such treatment. One of them is a TDCS. For me, it's an amazing tool. And that's why I did my PhD at the Neuromodulation lab with Felipe Fregni. And I think that it's so hard to translate that to clinics. And I mentioned before that it was really hard to get attention for these very small populations of patients. So my hope is that we can have clinical trials and have this translation to clinics and use all the treatments we have for like, with so many things that we can use for such patients that will increase either the comfort or the recovery for sure. And this is something that I will always work for. So this is my hope.
All right, Aurore Thibaut, thank you very much for this conversation.
Thank you so much for inviting me.
The CSN podcast was produced by the Convergent Science Network of Biomimetics and Biohybrid Systems, a project funded by the European 7th Research Framework Programme. For more interviews, recorded lectures, or upcoming conferences in the field of biomimetics and biohybrid systems, go to csnnetwork.eu. And thank you for listening.